I am Ramaswamy Govindan, a medical oncologist and a professor of medicine at the Washington University School of Medicine in St. Louis. One of the challenging questions in practice is that, which is actually a nice question, nice problem to have, how long do you continue checkpoint inhibitors after the patients have had a nice response to therapy in the setting of metastatic disease? First, at this time in 2021, we know that durvalumab, given as a consolidation therapy following stage 3 treatment of stage 3 non-small cell lung cancer with chemotherapy and radiation, should be given for a year. We know that very clearly from the PACIFIC studies. We don't give that infinitely, so that's a very clear 1-year mark. And for metastatic non-small cell lung cancer, it is not so clear what's the right duration of treatment. In the early studies, in most studies, patients got these checkpoint inhibitors continued indefinitely until progression or they have unacceptable toxicities. And then some studies capped it at 2 years. And some of the retrospective studies, people have gone back and analyzed, Julie Bramers and others have reported that 1 year is not enough, maybe 2 years. And it's not clear whether it's worth continuing beyond 2 years. And more recently, the studies have capped checkpoint inhibitors 2 years for maximum of 2 years. So my general rule of thumb is that give checkpoint inhibitors for 2 years if they're doing extremely well, no active disease, and I give them a break after 2 years, follow them very closely. On some occasions, anecdotally, these patients have progressed, have gone back and retreated them with the checkpoint inhibitors. They did fine. I continued for another year or two in some instances. But in general, after 2 years, I think it's reasonable to consider stopping this and watch them very closely.